I'm a neonatologist, I'm a neuroscientist, I direct the NICU follow-up program and I practice in the NICU, and I'm lucky enough to be an NIH-funded scientist. And I thank the NIH, the Cerebral Palsy Foundation, the Cerebral Palsy Alliance, the ACPDM for all their grants. They've been lovely to me. So today, I'm going to talk not just about implementation of early detection for cerebral palsy, but I want to talk about a trajectory from clinical practice to QI to research to show you that in anything, in neonatology or in any domain, having that continuum and back again is really, really critical. That research without implementation science is not a whole lot. I'm going to talk to you a little bit about the background of cerebral palsy and why neonatologists should care about it. I'm going to talk to you about, in clinical practice, elements of early detection in the NICU and then how they continue from the NICU onwards. And then I'll talk to you about how, through implementation science, we can implement these guidelines at a national level through a network and what the effects of that are, and then why that's important to research and showing you how an NIH-funded clinical trial, an RCT, then uses that sort of practice change to change the outcomes of your NICU babies. So if you think about CP diagnosis, it's got about 6 components. The first 5 are actually objective components: the clinical history, the neurological exam, a series of motor function assessments that show impairment, because cerebral palsy is a non-progressive, it's a disorder of movement and sensation originating in the perinatal period from a non-progressive insult. And then we want neuroimaging, obviously, biomarkers. We'll talk a little bit about some of those biomarkers. And then we absolutely need to rule out progressive disorders or other diagnoses. So why does this relate to the NICU? Well, in the NICU, more than 50% of babies who will eventually develop CP across the developed world are NICU grads. And this could be not just due to prematurity, but to infarcts, thrombosis, and obviously the whole spectrum of encephalopathy, either of prematurity, but mainly term encephalopathy. So before, we focused a lot on predicting cerebral palsy, which from a parent's standpoint is pretty useless. Now what we prefer to do is focus on surveillance and intervention. It's not enough to predict that a baby might have CP, because right now for a parent what counts is how is this going to evolve and what are we going to do about it. So this means that you need to have critical partnerships between neonatology, neurology, and comprehensive CP programs as early as possible if you're going to make a difference to your NICU patients. But there's a big challenge. This is the fact that CP is actually changing in the developed world. This is our results from Ohio that were published in JAMA Peds recently, but it turns out that the Australians published and their CP is changing as well. While the incidence of CP may remain the same or even increase in some cases, what is changing is the profile. And here what you see on the left is a cohort of, this is the year of birth of babies. And the circles represent how many babies are born, and the color of the circle corresponds to the level of cerebral palsy on the GMFCS, where 1 is the lowest and 5 is the highest. And what you can see, and it's the same as in the other figure to the right, is that there's an increase in the lower levels over time, and the higher levels are staying somewhat stable. So what we're changing is how CP looks, and it's making it more challenging to find early. Why is that happening? Well, advances in neonatal care have been playing a role. You know, some of the major advances, obviously surfactant, but in the last 10 years, more rigorous use of caffeine, probably the only true neuroprotective agents we know for premature infants, and cooling, obviously, some of the more systematic coolings for HIE. So what evidence do we have about early diagnosis of CP? Well, we have systematic reviews of systematic reviews. And in 2014, there was a big international convene of experts and stakeholders across not just all medical and research disciplines, but also with parents that were involved in this and community stakeholders to look at the evidence and identify priorities according to grade. And what came out of this systematic review of systematic reviews was that early detection should occur early because it allows for optimal developmental trajectories for children and best outcomes for parents. It turns out that there's strong evidence that parents resent and get angry when they think that something is wrong and that it's being hidden from them. And they lose trust in the medical system. They also have higher incidence of depression, anxiety, and problems later in life, which end up impacting their children. So, a sort of physicians are not parents to parents, and we need to understand that they want to know early. More importantly, in, let's see, September of 2019, this year, the Departments of Labor, Health and Human Services and Education put on the Appropriations Bill of the United States that the CDC, CP is the most common lifelong motor disability caused by early developmental injury, and it is now part of the CDC's budget and the priorities. More importantly, that early detection of CP must and should occur. So now we know that it's not just the science, the systematic review of the evidence, but the US government agrees as of September of this year. So what are the elements of early detection of CP? We're going to start in the NICU since most of us are neonatologists. So we're going to look mostly at what happens before 5 months of corrected age and what the guidelines tell us. So we know that a standardized clinical neurological exam, the Hammersmith infant neurological exam, an MRI, and a general movements assessments have the highest level of evidence together to help you predict cerebral palsy with greater than 95% certainty. After 5 months corrected age, we'll talk about it a little bit later, but if we think about this, we have a unique opportunity in the NICU to educate and to make sure that before 5 months corrected age, these children have a visit with all of these elements already in there. What are those things? So neuroimaging. How can neuroimaging help us? Well, it turns out in term infants, there are MRI findings on diffusion-weighted imaging and later T1, T2 that are highly predictive of cerebral palsy. This is from Linda DeVries, and you know, in the case of severe HIE, we have findings both for dyskinetic CP and obviously in the PLIC, the posterior limb of the internal capsule, for some spastic forms of CP. In the case of stroke, same thing. When we see lesions in the posterior limb of the internal capsule, we can also have a very high prediction for cerebral palsy. In preterm infants, it becomes a little bit harder. Sequential head ultrasound or cranial ultrasound has some value, but you can see that the prediction, especially for PVL, is quite low. And MRI at term equivalent age for that also. However, cystic PVL, we can have a very high predictive value on MRI, and also any lesions of the posterior limb of the internal capsule in these infants at term equivalent age have a very high predictive value. So head ultrasound is a problem, right? We all know that. We all know that just because we have a head ultrasound that only shows a grade 1 or 2 or doesn't show anything, that it doesn't mean that this child will not have a poor outcome. But we do have another tool that can help us, and that is the general movements assessment, and especially Prechtl's general movements assessment. This is the only one that's been standardized, validated. It's an excruciating process, by the way, to get certified. It's 3 days of going through a process of patterning your eyes and brain to recognize these movements. And there are many now therapists and physicians who have been certified. However, we do need to maintain our certification, not just by practice, but by recertifying on a periodic basis, because it is a pattern that you could eventually drift and lose over time. So it turns out that, I think this is a video, nope. You can actually, I am very sorry, these are both movies and they're not working. You can see movements that are called cramped synchronized movements, and the baby on the left is a movie of what that's supposed to look like. And these cramped synchronized movements have not great sensitivity, but very high specificity for neuromotor problems later in childhood. And these movements are highly recognizable to those of us who see them. They look almost like a baby who's folding, like a wallet folding, just, or a clamshell.
Escape slideshow, they might come up.
Huh. No, but that's okay. Thank you. If I have time, I'll show you. I have tons of movies. And this movement, sort of a synchronous activation of all four limbs and a folding of the baby into is highly characteristic, and it's a pattern. It's not you see it one time. It's a pattern over time. It's recognized on video. Same thing at 3 to 4 months, that sensitivity and specificity increase, the sensitivity especially for a pattern called absent fidgety, where babies who are seen have a lack of tiny oscillatory movements that we don't even notice most of the time in 3 to 4 month olds, but that are also highly predictive if they're absent for cerebral palsy specifically. So this is from a systematic review by Kwong with meta-analysis, and so these numbers are quite strong, but again, this is for Prechtls. So you think, well, what about in clinical practice? What could this look like? So we have a big NICU at Nationwide Children's, and we thought, well, the GMA we could do between 36 and 42 weeks, corrected age in the NICU, and we'll just do it for a year. What if we systematically did it for a year? What if we sent these out, because we're still not really sure of our impression, to the gold standards in Italy? These are the people who are from the Prechtl Trust, the people who teach the GMA. And we're going to enroll every baby in this that we can, and we're going to see, we're going to provide counseling, we're going to request MRIs from our neonatologist, and we're going to see what happens to these babies at 9 to 12 months in our follow-up clinic, using standardized exams in the first year. And so this is what happens. So we enroll 333 patients of all ages at birth and all conditions. We don't discriminate. And we first classify them on whether they had imaging or not. Remember, some babies in our NICUs don't even have that. And then what their movements are like. So some of them had normal neuroimaging. We had about 180. We had about 87 with no neuroimaging and 66 with abnormal neuroimaging. And that, by abnormal, I meant any spectrum of IVH and MRI findings. So we look at these, and we notice immediately that there are a lot more babies in abnormal neuroimaging who have cramped synchronized movements. That's not surprising. We look at the no neuroimaging group, and we find that 2 of those babies who normally don't qualify for neuroimaging have cramped synchronized movements. And in the ones who have normal neuroimaging, and by that I mean normal cranial ultrasounds, 9 of them have this. So we request politely from the 45 neonatologists involved and practicing throughout our network that they please do an MRI. 4 of them agreed to, out of the 11 that were needed. And it turns out that all 4 of those were abnormal. I'll show you a little bit. So if we look at all the babies out of the 333 that had cramped synchronized, some of them were pretty logical. Some of them had grade 3, grade 4, or hydrocephalus on cranial ultrasound, PVL. A few of them had cranial ultrasounds that were normal and no MRI, refusal of MRI, and you can see there are quite a few. And then there are those four that had normal head ultrasounds that we did MRIs on because they had cramped synchronized movements. And one of them, it turns out, was a 36-weeker who had HIE, and we didn't know, and ended up having CP. One of them had white matter edema in the parietal lobes, also ended up having CP. The other one had septo-optic dysplasia, and full disclosure, since then we've identified 2 other children with septo-optic dysplasia through general movements. I have no idea why. I wish I could tell you, but for some reason this is affecting movement patterns. And then one who had a hypoplastic cerebellar vermis has an abnormal neuromotor exam, and complex genetic workup now is going on. So you can see that when cramped synchronized movements are present, there are only 3 times that the child was typically developing. 2 of those times were a child who had gastroschisis and abdominal surgery, and we did a GMA. We performed a GMA on this child within the week after the surgery, which was probably not advisable, because if you think about a movement that is about going through the body, probably when you've had your gut pour back into your body, you're not feeling like you can move your middle very much. So now we've changed that a little bit, and in children who have abdominal surgery, we wait until they are on enteral feeds, at least on full enteral feeds, before we even consider doing the movement patterns. It's suboptimal. I can't even tell if a baby's on full enteral feeds if their gut is feeling good or not, but we've just decided that we're going to do that. And then there was only one case where a child had normal head ultrasound, no MRI, and ended up being typically developing so far at 9 months. So this is just clinical practice. So this made it very easy for us to then make the GMA standard care. And now in our NICU, every baby who reaches 36 to 42 weeks gets a GMA. It takes 2 minutes. It's a video. You look at the video and you decide whether the baby's at risk or not. For the time and money spent on it, it's pretty much worth it. So then, why in this whole process is it important to partner with at least neurology in the NICU? Well, we do great cranial ultrasound monitoring. We can even do general movements assessment. We can manage perinatal complications. We can provide hypothermia and fantastic developmental care. But they're really great at interpreting complex neuroimaging, managing seizures, guidance on EEG use, management of infarcts and thrombosis, and then there's a place where we can both meet. Neurological exams, neonatologists, many of them, can learn how to do a standardized scoreable neurological exam. Counseling, follow-up, and making a multidisciplinary plan for these children before they leave the hospital. And that is what we are moving towards. I would be lying if I said that this is smooth at this point. We're working on it. So then early detection of CP continues from the NICU onwards into the clinic. And there are 2 primary types of patients. We can see the ones that have newborn detectable risks. This is from the guidelines that were published in JAMA Peds in 2017. By Ono Novak. You have the preterm encephalopathy and some history of neurological risk factors. And then you have the ones that are going to be referred by pediatricians in the community, or just concerned parents or therapists that are concerned, that could have gross motor milestone delays or early hand preference. So in the NICU follow-up clinic, we see many of these, some from the NICU, some from the outside. And we can use the same kind of standardized elements that were reviewed in the systematic reviews to then check what to do. One of those is the Hammersmith infant neurological exam. This was an examination that was developed by Lily Dubowitz. Some of you know her because she's done other types of examinations in the NICU. But this is a standardized and scoreable neurological exam, and it is valid in infants with optimality scores from 2 to 24 months. It has 26 items that assess 5 domains. They're scored individually with a global score, and you also can get an asymmetry score. Very standardized exam that's highly predictive for problems later on. So how do you incorporate this into a journey? Let's say you've got a high-risk baby from the NICU and you want them to be seen. Well, this is just one example, and we published how you could implement guidelines for surveillance throughout a NICU journey. If you think about the red dots, those are your red dots that are your standard visits that any baby would get for screening and surveillance. And the blue dots are the more targeted ones. You've found something that's not quite right and you want to check it. In the standardized visits at 3 to 4 months, you would do a test of infant motor performance, for example, a general movements assessment, and a standardized neurological exam. Obviously, developmental history, medical exam, all these other things, care coordination. At an interim visit or a targeted visit, you might do something different. You're checking just on a progression of a neurological exam. If this is CP, it's not just going to go away. CP doesn't mysteriously disappear. I know some people think of children who outgrew CP, but maybe it wasn't CP, and maybe it wasn't followed longitudinally in a way that would tell you that. So one of the things we do is we repeat. These assessments have more value, just like the Bailey, if they're used as trajectories, than if they're used at a single point in time. So we also might, once we diagnose with CP, follow these children with a GMFM66, which gives us a really good idea of what that child's developmental progression will be. And then you need to use comprehensive care models, because it turns out that CP, while it's a sensory motor disorder, actually is associated with a host of comorbidities that are just as important. Feeding problems, as I mentioned, sensory, so vision, hearing, tactile problems. Other comorbidities are sleep, pain, behavior, communication. There's a long list. It's been published. Iona Novak did a beautiful job in the Journal of Child Neurology in 2015 doing that. So you pretty much need early diagnosis, but then you have to have evidence-based treatment at your institution, otherwise you're diagnosing but you're not knowing what you refer to. Frequent standardized longitudinal surveillance, rapid referrals, and not just for diagnostic studies but to specialty providers. And why do you do this? You do this because we know that programs that are targeted at the earliest years have the biggest return on investment. This is James Hatton's work, Nobel Prize in Economics. He talked about children who are in socioeconomically disadvantaged settings and showed that the return on investment of programs at the 0 to 3, in the 0 to 3 age range for a healthy, both physically and mentally healthy workforce, productive workforce by adulthood, those programs had the largest return on investment. I would argue that brain injury is just one other form of disadvantage, and we know that it affects those who are socioeconomically disadvantaged disproportionately. Most of our NICU patients are skewed. For example, if you think in a program, well, overall in a hospital, children's hospital, your Medicaid population may only be 40%, let's say. In the NICU, you all know that it's much higher. And that's just the risk factors that give us preterm infants or those with congenital problems. So we know that the earlier the intervention, the greater the impact. So what we want to do is intervene early. But to intervene early, you have to detect early. So it's sort of a cycle, right? So we talked a little bit about clinically how we could do it in the NICU, but it turns out we can implement this using QI at a national level. So the CP Foundation funded a network, the CPIDI network, 5 large institutions across the country, and their goal was to change the gap of evidence to practice. And as you all know, those of you who do QI, research to implementation gaps, we always quote an average of 17 years. It turns out the paper that quotes that by Morris actually shows that it's 3 to 28 years. 17 is just the average. And unfortunately, optimal plasticity of the human brain and body is in years 0 to 3. So in 17 years, you have a lot of generations who might not benefit from things if you don't. You're not talking about a lifetime. You're talking about the life of plasticity in the brain, which is still present in adults. I mean, we have some degree of plasticity. We have to hope that, otherwise it means we're just decaying day by day. But we still are plastic, but never again the way we were when we were 0 to 3. And the best way to see is think about it this way. If you, right now, had a stroke, right now, would you want to wait 3 years or even 2 years until someone did something about it? Not really, right? So why in babies do we think that it's okay to watch and wait? So the average age at diagnosis in the US is between 19 and 24 months. We know this. And we knew that implementation of a single guideline tool can happen locally in 2 months and of the entire guideline set in 12 months because we published this. So we figured if we can do it this way, let's close the gap, and this time let's do it through a network. So this is our network. We had 5 centers that represented 520,000 square miles and a population, a catchment area of about 32.53 million people. Our sites were the following. They had a huge mix. Some of them were rural predominant, some of them were urban predominant. The literacy rates ranged from illiteracy, ranged from 3% for one of the sites, C, to almost 25% for one of the sites in Ohio. That's us, Appalachia, doing really well there for literacy. So you can see that the NICUs were fairly consistent, except in the size of them, that they had annual admissions of HIE and small babies that were quite variable, and their clinic personnel was also variable. One of them had no clinic when we started. The aim that all sites has, their primary aim, was to bring the age of cerebral palsy down to below 12 months. The process measures were the number of 3 to 4 month visits, and balancing measures were parent perception of the diagnosis and no-show rates in the clinic. Because anytime your no-show rates go up, people are unhappy. So implementing guidelines should not decrease the efficiency of your clinic. So this is what ended up happening. We used a whole bunch of PDSA cycles. I won't bore you with all our key drivers and everything else. And we looked at our primary outcome and process metrics. Our weighted average age at diagnosis by implementing these guidelines across all 5 centers went from 19.5 to 9.5 months. This after a period of 3 months of preparation and planning and 9 months of implementation, so 3 trimesters. Just so you know, this has been sustained since. So that was better than we ever thought. And I will tell you that it has not gone down below 9.5 months since. So we seem to have reached a level which is pretty much going to stay there, no matter how much we might want it to get lower right now. The other thing we looked at was the number of 3 to 4 month visits per site. And I don't know if I have a pointer. Yeah, I do have a pointer. Look at that. There we go. We started off with very few visits in the first trimester, and you can see that over time, the 3 to 4 month visit with all elements of the guidelines that were compliant with that went up substantially. And that's what the process metric that was driving our outcome, we knew that. And finally, in the last graph, you see the new diagnoses of CP. And we saw that we were not having more children with CP, most likely. We were just diagnosing them earlier. This is another way of looking at it. This is the cumulative numbers. If you just look at the numbers over time, it tells you the same thing. New diagnoses CP, however, are increasing. Over all 5 sites, they're around 350 after 9 months. They started off much lower in this control chart if you look at that. However, the difference is not significant yet due to the high standard error. So we knew that we could implement guidelines and we could detect these children earlier. But what's the point of detecting if you don't do anything about it? If you just sit on your hands and you say, I'm so sorry, your child has CP, and then you don't tell them about all the evidence. Well, it turns out that parents kind of felt that way too. And I'll show you a little bit about this. These are parent perceptions surrounding early diagnosis. First of all, we saw that even though we were doing a decent job, there's lots of green and blue, there's definitely opportunities for improvement. Parents wanted providers to show that they cared about their feelings. They wanted to show warmth and support. And while everyone agreed that the providers were honest and direct, there was some room for warmth and support. The more important thing is that if you look at how things were told to them and about interventions and the diagnosis in words that they could understand, if you look at this, yeah, it looks like there's a good amount here, but there's also a good 30 to 40% that said this was not in words that they could understand. And that the information about the diagnosis was not necessarily exactly what they wanted either. So I will tell you that since then, we have put out multiple questionnaires to parents, and we have hundreds of them now telling us exactly what they want to know when they get the diagnosis, because that was definitely an opportunity for improvement. To be clear, the no-show rates, which was our other balancing measure, remained completely stable during the entire time, and the business managers were very happy that it did not decrease their show rates in the follow-up clinic or decrease the number of visits. So I told you what parents wanted and what we were able to accomplish. It turns out we do need to fix what we tell parents, because there is growing evidence for CP interventions for the 0 to 3 age groups. There are currently, right now, funded 8 NIH trials of interventions for children with CP in the first year. 12 CP Alliance trials, another entity that funds this, in the first 2 years. 23 ongoing clinical trials for infants with CP on clinicaltrials.gov. More than 12 systematic reviews of interventions for high-risk or with CP infants under 3. And this is just, in the past month, you can just keep running this search, and you'll find more and more publications on the topic of interventions in this age group. And now that we're diagnosing them early, there's no excuse to not do more. So I'll show you, as a last thing, this clinical trial. This is the first time I'm talking about these results. This is an NIH-funded clinical trial for infants with CP under the age of 2. And I'm going to try to handle 2 computers at the same time. I'm not super great at that, so bear with me. So as I mentioned to you, CP is a disorder of both motor and sensory system. And infants who have CP have faulty, difficult motor learning. This is because when the brain calculates how to make new movements, it uses a Bayesian probability machine. It uses old movements to make new movements and refine them based on prior experience of movement, sensory feedback it obtains from movements as they're performed. And infants with CP have decreased movement experience and increased sensory noise, which both contribute to the poor quality of their movements and to their motor learning. So in addition, we know that treatments that remove sensory feedback to the brain during a critical period of time can alter the development of sensory systems such as touch or vision. I don't know if any of you have heard about cats who are deprived of vision early on just by putting something over their eyes. They will never recover vision after that critical period, even though there's nothing wrong with their eyes. Their brain just never developed that way. You can let them see. You take off whatever bandana is over their eyes and they can see, but they can't see in their brain. So, in addition, when we think about treatment for disorders that involve sensory systems, one of the things we need to make sure in the NICU and beyond is that they're safe. And often, rehabilitation trials have not been held to the same standards. In every NICU trial, we always have to prove safety, right? We're always like adverse events, we're always looking at these. Well, believe it or not, in rehabilitation, that hasn't been the standard. All they have to do is show efficacy, and they don't have to prove safety. So the NIH is starting to change that, and this is one of the first clinical trials that has measures of safety built into it, because we know that when we deprive a child, a growing child, of sensation through a rigid cast on their extremity for any length of time, we actually change how their brain, and that's the thing you see on the right, how their brain is going to feel things in an extremity that turns out was good to start out with. So we can actually do harm. So this research study aimed to demonstrate that a multimodal parent-administered sensory motor intervention could effectively improve both sensory and motor function in the more affected arm and hand of young children who had asymmetric CP, while remaining safe for the sensory function of the less affected hand. So to achieve this goal, we did a randomized control trial with a waitlist control. The reason for the waitlist is that when an intervention for a parent of an infant with cerebral palsy could prove successful, it's almost impossible to enroll if you tell them they will never get the intervention. Does that make sense? I know in the NICU we have that problem too. If you think about the number of studies where parents won't consent and would prefer physician preference, because what if their child doesn't get the right intervention or the best intervention? So in this case, we did a waitlist control, where the first group got it for 4 weeks, and then after that, the control group got to have it as well. The inclusion were any children 6 to 24 months with CP and a Hammersmith infant neurological asymmetry score above 6. They also had to have neuroimaging findings that were consistent. We had a few exclusions, and our primary outcomes were cortical somatosensory function, smoothness of reach on 4D kinematics in the more affected upper extremity, and unimanual and bimanual development. There were safety outcomes. Again, somatosensory function, but this time in the less affected upper extremity, gross motor and bimanual function. And there were measures of fidelity of intervention because it was parent administered, and we'll talk about the CMIT. It was powered for 36 infants with CP per group. And this is what it looks like. Babies had to wear this soft constraint, this CMIT, 6 hours a day on their less affected upper extremity. They could still do everything else with it. They had to do reach training with sticky mittens that had Velcro on them, that were put on their more affected extremities so that these babies who'd never been able to reach something could actually feel what it felt like to reach and capture something. And then those objects were progressively increased in weight and bulk so that they would progressively get more and more sensory feedback there. They had motor sensory training, again with a mitt on, bimanual play because you have to wire both sides of arms and brain to make things work, and then parent education and positive reinforcement, just right challenge, a whole bunch of positive psychology skills and part of the toolbox that were given to them. Our measures were taken at baseline, 4 weeks, 6 months, and 3 years. We had time-locked EEG. You can see a baby who has a high-density EEG net on, and we're measuring her sensation there. We had kinematics of reach, which is motion capture, basically, you know, Lord of the Rings and things like that. And we're able to measure what reach looks like. And the babies also had the Bailey 3 motor. We attempted to mask things there, but it's very difficult because the parents knew. The other two are very easy because they're objective blinded data, right? You just put them in the computer and the people who analyze them don't know what group the babies belong to. But with the examiners, it's very hard sometimes to tell a parent, please do not tell us which group your baby was in. Our participants were largely preterm infants. If you see what their neuroimaging showed, the spectrum, 70% of them were actually preterm infants with a spectrum of encephalopathy of prematurity as their main lesion. Some of them were HIE and some of them infarct thrombosis. Parents were very compliant with the CMIT. They were supposed to wear it 6 hours a day for 5 days a week. And we were shocked to see that on average, they wore it 38 hours a week. So I'm not great with math, but I can tell you that's more than 30. And they wore it for that 38 hours a week for 4 weeks. The fidelity of parent training, which was done by 2 independent examiners, showed that the parents actually understood this treatment very well with a fidelity to the initial treatment of 95.3%. These parents, just so you know, came from a wide variety of socioeconomic spectrum. The 48% of them had only a high school education or less. And on the Barat social measure, 78% of them were below middle class, and there was just that last quartile that was in the middle class. No one was above that. And our primary outcomes showed that we could change sensation of touch in the more affected extremity. And using the EEG measure, we showed that it improved substantially. It actually, just so you know, compared to typically developing children, there are 214. They're not part of this RCT, but it almost normalized compared to those children who are typically developing. The kinematics of reach showed that, so the number of movements is a measure of smoothness. It turns out that if you think about how you reach for something as an adult, we're very smooth. It turns out we probably have 1 or 2, maybe 2, if you think about how my movement is going towards something. But babies with CP sort of have this halting movement that is decomposed in many movement units. And what we showed is that we were able to decrease those number of movement units. That's the computer that calculates it, not us. And then the Bailey also showed improvement. Pardon me? No. And just so you know, the Bailey is not the optimal measure because it's not designed to measure, it's designed to measure development over time, not function. That's why we had the other 2 measures. Our safety outcomes showed there was no difference between the 2 sides, and that before and after the intervention, things stayed fine. Our gross motor scores did not go down. People were concerned that by putting that mitt on babies, maybe they wouldn't learn how to crawl. They were very young. It did not happen. They made lots of progress, just like any other kid at that age. And our bimanual scores also did not decrease. That's one of the concerns with constraint. So then we tried to see, in more like a sensitivity analysis, were there some populations that benefited more or less? And it turns out that the preterm babies benefited more from, at least from Bailey score, from the standpoint of Bailey score increases, than either the ones with term encephalopathy or infarct. And female babies seem to not benefit quite as much as male babies from in terms of the smoothness of their reach. But what mattered most across everything was the hind total score. Basically, the severity of the neurological exam did have an impact. The higher the score, which means the less affected the child, the better they did. That's been found in other studies. This is not novel. So this is the conclusion to that one, to that particular research study done in babies with CP. Like I said, 72% of them are preterm. And we know that an upper extremity intervention is safe, it's effective, and our 6-month result just came out today, and they show that the results increased over time in both groups, but we're still waiting for the 3-year trajectories that are comparing them to a cohort of 214 typically developing children, and those will be completed in 3 months to hopefully further support the fact that the trajectories are becoming closer to each other. So, whoops, and I can't spell. Look at that. To put it all together, everything I've told you about. So early detection of CP matters because early intervention works. Parents want to know so that they can get the support and education that they need. Early detection can start in the NICU with great neonatology and neurology partnerships, and early and effective interventions for CP can start as early as diagnosis does. So I want to thank a whole bunch of people. I'm going to put them all here, and some of the kids that are involved in this study, including my 2 children that you see up there. This is the slide to embarrass them that I will keep putting up at probably their wedding. And then just a reminder that we focus a lot on implementation of research. Research is very little unless we have the wonderful people who choose to do QI and implement things, both before to allow us to do the research and after, so that our interventions actually become a reality. Thank you.